Hi, Anita.
Hello.
Hi, how's it going?
Good, and you?
Better.
Do we have someone in early?
I'm not
So just-
sure.
Yeah, I'll let people in if they want to, if they're on the panel.
Okay.
Okay. I also sent the list, even though it's not in an attachment format, my 365 is deciding to give me a little bit of a,
Yeah.
so there's at least 65 plus.
Yeah, no, that's good. That's a great group.
Yep,
Awesome.
yep. Yeah, for whatever reason, I think it's user error right now to save the attachment, but I'll get it to you guys. I'm going to work on that in the back end if I can send it in a better format, see what's going on.
Hi, Katie. Dr. Grotz, you're
Nope.
confusing me with Katie.
Oh, no.
Oh.
Thanks. It was buried in my emails, but I found the link, so I think it works now.
Oh, perfect. But you're gonna confuse people. They're gonna think you're Katie. We have to change your name.
Okay. Do I do that? I think I can do that,
You
right?
can do it. I think I can do it, but if you want to give it a try.
Here we go. I got it.
All right.
How's
There
that?
we go.
All right. Good.
Oh, one of I was thinking, I think, well, we'll just go with the flow, but, those first questions for people that don't know who PMP is,
Yeah.
I'm kind of thinking before we let Andy tell his story, I would probably kick those questions to you first so we could frame it. And then we would have Andy tell his story. And then I think everybody involved with his story talk a little bit about your role in
Yeah.
getting Andy to where he is today. And then we would dive right into the other questions, and we'll get more in the chat, and it'll just be a spontaneous.
All right. No, that sounds good, because I'm imagining you have people from all
Yeah,
parts, right, who are just starting, and people who have, like you, 11-year survivors, and
yeah,
so that might be not a bad idea.
yeah. Yeah, but
So
I thought, because there's this thing just can't be linear because we're doing so many things. And I do think it's
Yeah.
important for Andy to tell his story, but for those that aren't familiar with some of the terms and things, then I think setting that foundation would be good.
Yeah.
So,
Yeah, I'll try to be brief. Like I said, I want to focus on Andy's story, but I'll just give kind of a brief background.
well, no, and I think every single one of you played such a role in his getting to where he is today that I think it would be nice to for you to talk about your role in his story, but then we'll once the floodgates open, we'll have all of those questions. And
Okay.
so, Dr. Grotz, let me introduce you to a few of my colleagues. So
Yeah.
Charmaine.
Hello.
And
Hi there, Dr. Grotz. Thank you for being here.
Of course. Thank you.
yeah, and Charmaine is also a patient, and we always stagger at the number 25.
Yes, in October,
Wow.
25 years since I was diagnosed, and I had my CRS HiPIC with Dr. Sugarbaker 13 years ago. So,
Wow. Yeah. Congratulations. That's
Yeah.
awesome.
yeah, thank you.
Jamie, another one of our awesome volunteers and a patient.
Hi, Jamie.
I've been thriving for a few years now.
Good.
And Connie is caregiver to her husband.
Hi, thank you
Connie.
for doing this. Hi, my husband, it's been 6.5. We're down in Miami, so Dr. Mahler.
Hmm.
So yeah, 6.5 years.
Wow,
This
good.
is gonna be great. I can't wait to hear everything.
Yeah.
A lot
Nice
of
to
people
meet
are
everybody.
saying, we have 76 registered. We'll see.
That's great.
Yeah.
Yeah.
And then Anita from Cleveland Clinic, and I don't know if Anita
Right.
can hear us, but I'm glad she's on. Oh,
We have Canada, Israel, the Netherlands, Belgium, Saudi Arabia,
Great.
and the state, Australia. We've got several from around the world.
Wow. That's great.
Yeah.
Dr. Grotz, one of
Yeah.
the about the surgery that has kind of been on my mind, and Adele might have mentioned this or put it as a prepared question, is I think patients will really want to hear about what potential the multi-organ transplant opens up for things like just something more limited, like a small bowel transplant. Because so many of our patients have small bowel involvement that makes them inoperable. You know, the HIPIC is an option for them. We have several people that are doing systemic chemo because of that. You know, they always feel like they're missing out on something. Of course, that's an issue, but you know, that extensive involvement is really something that concerns so many of our audience. So if you just think about that and see how you can work.
It's the number one question, Charmaine. I think Dr. Grotz, I gave you a heads up, but
Yep.
yeah, that is one of the top questions.
Yeah, because I think, you know, of course, people are going to understand that this kind of procedure is going to have pretty limited usage, but there could be some wider applications. I met a surgeon in Houston years ago who was doing some bowel transplants, but it was just so new back then. I don't even know how long ago that was, 7 or 8 years. And, you know, she wasn't sure that it could ever really do a lot for our population, just the stage that things were at that time. But I'm sure there's developments that have occurred.
Yeah.
Yeah. I mean, I think the Cleveland Clinic transplant team will be able to talk a lot about the outcomes and the immunosuppression and things like that. But you're absolutely right. I mean, that's and that's kind of what I was going to talk about. I mean, that's what limits the surgeon, is that we have to have good quality of life afterwards. We have to have patients be able to digest and do, you know, live. And so that's what stops us from doing, you know, surgery when we can't. And so if you can transplant you know, an organ, or, you know, grow an organ in a lab, or use pig organs, or come up with some way to replace the organ, then that really takes away the handicap that surgeons have, because now we can remove it all and then have an option for people. So that, I mean, that's exactly what you said. And that's kind of what this is the start of, hopefully.
That's right. It's going to be wonderful. Yeah. And there's Andy and Rachel. They've joined in.
Hi, guys.
Hi.
Hello.
Hello.
Hey, Andy. Hey, Rachel.
Hi.
Good to see you, Dr. Grotz.
Yeah, good to see you guys again.
It's been a long time.
I know. It has been.
Lots happened.
Yeah. Yeah.
Yeah.
Hello.
Oh.
Hello. Signing in. I think Amy from Lightner join us in the same room. Makes it easier.
Hi, Dr. Vaidya.
How are you?
Good, thank you.
Paris
Hello.
Hello. I'm going to be back in one moment.
and the two usual suspects that It was 6 o'clock, right? We're on time. There was some confusion about the time. I thought it was 5 o'clock. So getting ready
That was
for
the placeholder, just to make sure I had you.
Anita wanted to make sure. Oh,
Exactly.
The truth comes out.
that's right.
I'm laughing because I worked in surgery, so I get, you know, you on time. Yep. Tell a little lie. Come on.
Yep. Yeah, so I mentioned this to Dr. Grotz, but Andy, Rachel, Dr. V, what I thought was, I mean, we'll go through our normal disclaimers and then we'll do introductions. And then we'll go into Andy telling his story. But before Andy tells his story, those early questions on, you know, what is PMP, what's the traditional treatment, I think it would be better to start with those for Dr. Grotz to field those, so that those not familiar with this have some background. And then I thought, you know, Andy, you could go into your story, and then we would go around with Dr. Grotz, you know, Dr. Vaidya. I want to make sure I say your name correct. Vaidya?
Just call me Dr. V.
Dr. V, okay, okay. Dr. V, Dr. Lightner, and then Rachel, on your role in Andy's story, and then we would go through, I sent out the list of questions in advance, and it would be, it'll be spontaneous, and we might get interrupted, we might get on tangents, but feel free to jump in wherever you think is appropriate.
Super.
Thank you.
Sounds good.
And we did see the other news story on the other patient that got approved. We're so excited.
Yes, that was fantastic.
Yes.
Good.
Yeah. Okay, that's Dr. Lightner. The person who made all this happen.
Hi, Dr. Lightner.
That was today.
Oh, hey, Travis.
Hey, good to see you again.
You're just a little small box on my screen.
Yeah.
I didn't even recognize you.
Yeah, good to see you again.
Good to see you too.
I don't think she heard the format either. Adele, you might want to let her know.
Oh, okay. So Dr. Lightner, what in terms of order, we'll do our normal PMP Pals disclaimers, and then we'll go around and do introductions from all of you. And then, the wanting to spotlight Andy's story, but just before Andy gets to his story, I thought it would be good for Dr. Grotz to field the questions on, what is PMP, what are the conventional treatments, so that those not familiar with this space that might be joining us have that foundation. Then we will let Andy tell his story, go to Dr. Grotz for his role in Andy's story. And then I think between Dr. V and you have to decide who should go next. And then Rachel and Rachel's critical role as the caregiver. So telling the story, and then we would go right into these advanced questions. And we'll probably get some questions in the chat. We might get interrupted, and it will just be as spontaneous and go with the flow as we can.
Sounds good. That's good.
Is Nita coming in here?
Yeah. Shall we start?
We've got a few more minutes.
Yeah.
Well,
Oh, yes, of course.
Yes,
Well,
yes, but we
yeah,
have
we'll-
close to 70 people that registered.
Wow.
And
Like,
we
Adele,
found
would you
that-
like me to pull up the slides, or is somebody else doing that?
No, I did a shorter version of the slides, so I can share my screen this time.
Perfect. I'm just gonna leave my cam off unless you call on me, and I'll take care of admitting people.
Okay, thank you.
Dr. Lightner, I think this is the first time I've seen you without a mask on.
Is it?
I think so. I think even like the first video we had, everybody was still wearing masks.
It really does happen.
we've found too, as we've gone along with these programs, that our crowd has learned that there's no reason for them to get on early, so they kind of start coming in through about 5 or 10 minutes into the show, because they
Yeah.
do intros and things at the beginning. So I'm sure we'll have people joining us, a few minutes after we start, but we'll let everybody in at the starting time, and then Jamie will let the other people in as they get settled in with their cup of tea or whatever.
I'm happy that goes in there.
we thank all of you for doing this, though, taking the time.
No, not at all.
Our pleasure.
I want to just say that the doctors in this community have been so generous with PALS. We've had So much great participation, and it means so much to us to be able to present this kind of information to this community. It's really great. We feel very, very honored to have your participation.
Hey, Anita, there's a third Anita in the waiting room. Do you want me to let her in?
You know what? I tried to join with Andy. I was all alone. I backed out. I came back. So maybe my other self is having a cup of coffee in that meeting while they wait.
No,
So
well, admit,
I'm just
admit
gonna
all,
let her be there.
the third you will be joining.
I don't want to blow us being in, so we're just going to keep it.
Before we start, I just wanted to say it's nice to meet all of you, and especially you, Rachel. Nice to see you.
Yes.
Yes. The role of the caregiver is not to be underestimated.
No.
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 Screen. Maximize the window.
How do you?
That's why we're always on my computer. He's a little technically challenged, so.
Yeah, they'll just, the other
Oh,
one.
Looky there.
now I can see.
There's more than thumbnails. Hello.
Yes, we already have two Anitas in the meeting, and there's yet another one that will come in when we let everybody in the waiting room in.
Perfect.
Mhm.
I would love to meet her.
You probably wish there were three of you.
Absolutely. Right now I do.
Are we ready to start?
I think so. We've got about 40 people. I'm sure we will jump, but yeah, let's let people in.
Here they come.
Hey guys.
Hi, welcome everybody.
Hello.
You're on or? Okay, we're muted down here, are we?
We're not muted. Jamie, are you able to mute?
Yeah,
Yeah,
it's
we
set
will
to do that,
ask-
but
Yeah. All right, we're still letting some people in. It looks like we just have a couple of more. Oh, goodness. Okay, welcome everybody. We will get started in just a minute. Okay, welcome everybody to this special Thursday edition of PMP Pals Hope Zoom. For those of you that are here today, we are telling the story of hope and the very special story of Andy Voge being the first multi-visceral transplant patient in the US, joined by his team of medical experts that got him to where he is today, and his amazing wife and caregiver, Rachel. And so this is going to be a spontaneous dialogue to learn about Andy's story and to learn about PMP and an option for the right patient that we could only dream about years ago. So my name's Adele Jason, a volunteer with PMP Pals, and I will be your host for this session. Before we get started, we have just some information about PMP Pals and some disclaimers I want to go through first. So I will share my screen. All right, can everyone see that?
Yep.
Okay, well, PMP Pals is the world's oldest global volunteer-run organization that gives hope to patients and caregivers fighting appendix cancer, also known as PMP. We provide these forums to provide fellowship among patients and support, but we are not licensed medical professionals, and we're not providing medical advice. Patients must seek out their own licensed physicians who are qualified to develop and provide appropriate treatment plans for your situation. So even though we have medical professionals on the call today, this is educational only and may or may not apply to your situation. Sometimes our presentations have data or images that are a little scary. We don't have any graphics today, but just to make you aware, by participating in this forum, that means your identity and health condition may be shared with the public. While you have the ability to turn your camera off and change your name, we can't guarantee anonymity, and some of your identifying information might be displayed. And so by participating in our call today, you are giving PMP Pals permission to share your likeness with patients, caregivers, physicians, and other interested parties. And as a reminder, please check out our website and our Facebook page and Instagram to learn more about our programs and stay in touch with us. So with that, I would like to start making our way around and introduce our special guests. And I'm going to start with Andy.
Hello, I'm Andy. This is my wife, Rachel. I think most of you I recognize. So yeah, it's good to see everybody.
Okay, Dr. Grotz.
Good evening. I'm Dr. Grotz from Mayo Clinic. I'm one of the physicians caring for Andy.
And the Cleveland Clinic transplant team.
Transplant surgeon, did the first transplant for PMP about 10 years ago in Oxford in England.
Dr. B, I think we're having a little trouble hearing you.
A bit closer. Is that better?
Oh, much better.
Yeah, much better.
Okay, great. So transplant surgeon, very interested in the interface between oncology, that's cancer, and transplantation. Did the first modified multivisceral transplant for this disease process in Oxford about 10 years ago. And over the last 10 years, I've developed that practice. It's not big numbers, but what we've known now, last 10 years, is that this is perhaps one of the options for patients that may qualify for it.
Thank you.
Hello, I'm Anita Barnowski. I'm an RM and the transplant coordinator working with Dr. Vaidya and Dr. Lightner.
I'm Dr. Lightner. I'm a colorectal surgeon and had worked with Dr. Grotz back when I was at Mayo before coming to Cleveland. So fortunate to have created the dots between the two organizations to help take care of Andy.
Oh, well, thank you all for being here. And before we get into Andy's story, we may have some people that have joined us today that might not be familiar with the PMP space, or pseudomyxoma peritonei. So I'm going to ask Dr. Grotz to explain this disease. Tell us about it.
Sure. I'm happy to give a little background information and context for Andy's story. So pseudomyxoma peritonei, or PMP, is actually kind of a general vague description of just mucin or jelly or kind of snot in the abdomen. And it can be made by actually several different tumors, but most commonly it's appendix, and that's typically what we talk about when we're talking about PMP. But it is important to know it can be also ovarian and pancreas and some other rare tumors. And so these tumors obviously start in the appendix, and then they get outside the appendix. They either kind of ruptures or bursts or grows through the appendix, and then they get into the abdomen. And so they land on the surface of your organs in the abdomen, and then they make this mucin, this jelly, and that's what fills the abdomen. And they can be very indolent and slow growing, but they can also be very aggressive. And so it's a little heterogeneous, meaning that there's differences in different types of tumors, how active and aggressive they are. But traditionally, these are pretty resistant to chemotherapy and pretty resistant to immunotherapy. And so surgery is really the primary and treatment. And as a surgeon, the biggest challenge for us is being able to remove all the tumor and leaving healthy functional organs behind. And so when we see patients for surgery, we're trying to look at CT scans or MRIs, and sometimes we do laparoscopies or surgeries where we look in with cameras to see if we can get all the tumor out. Because if we can cure some patients, and we can really achieve long-term survival. Unfortunately, when we can't remove it all, the best we can do is kind of a debulking surgery is another type of surgery people talk about, where we remove as much as we can, leaving some behind. And we can often repeat these, but ultimately, that there's still tumor, and so it isn't a curative type treatment. So that's kind of where we are with PMP, and I think that gives a little context maybe for Andy's story.
Yeah, thank you, Dr. Grotz. So again, Andy, if you could, share your story.
Okay. So I know a lot of you know this, so I'll kind of try to make this relatively brief, but I was diagnosed with PMP in January of 2019. I was fortunate in that my local radiologist diagnosed it correctly, like off my CT scan. I was on a Friday, and then Monday afternoon, I had an appointment with Dr. Grotz at Mayo, which it took years for me to realize how lucky I was to get to that point that quickly. But we did, which was great. And then we did surgery February 22nd of 2019. It was a debulking. We knew from the beginning, Dr. Grotz was pretty confident that he wouldn't be able to get it all. But he did remove a lot of it, and we hoped that it would, slowly grow back and give us more time. It was about 18 months later, in August of 2020, my stomach stopped working. The tumor had kind of encapsulated my stomach to a point that it just lost motility. So I got put on a feeding tube. I was on a feeding tube for about 6 months, had a lot of complications with it, just couldn't get my hydration up, couldn't get my potassium up. And then in February, in December of 2020, I decided to try a round of chemo, and I did that because it was a prerequisite to another clinical trial that I was trying to get into. So I did 3 rounds of FOLFOX, and then in February, I had a bowel perforation and an obstruction. We were able to put some stents in to kind of open the bowel up a little bit, but it was about a week after that, 2 weeks after that, I had a perforation, and then we kind of decided that it wasn't feasible to use the bowel anymore. So the day I had the perforation, I was in the hospital. When they found it, they gave me like a 50-50 chance of making it through the night. And then my palliative care team told me that I probably wouldn't leave the hospital. But we did, made it through, left the hospital on TPN. And at that point, it was probably figured about 6 months left until it was over. And then about early to mid-April of 2021, Dr. Grotz called me and asked if he could discuss my case with a transplant surgeon. And I said, sure, what the heck. And then in May, I met, we did a video meeting with Dr. Vaidya and Dr. Lightner and Anita, and discussed the possibility of a transplant. And I had, shortly after my first surgery, so back in like early 2019, I had read a story online about a guy who had a transplant in the UK for PMP. And I distinctly remember sitting at my desk reading it. I was at work, of course. I was reading it and I thought, man, this is nuts. Like that's crazy. And he was in the UK. They couldn't really find anything else about it. So like, I didn't even tell Rachel about it. Like, I just thought that was nuts. And then a couple days after meeting with Dr. Vaidya and Dr. Lightner, I got in contact with the guy. His name's Adam. And he kind of walked me through a little bit of like his story. And I found out that, you know, I had the chance to have basically the same treatment he did. He was very close to dying when he had his transplant, and that's been 7 years ago. And so after talking to him, we kind of decided we didn't have anything else to lose. So I did a transplant evaluation, which is like a week-long set of appointments, like a lot of appointments. They kind of check out everything to make sure that you're a candidate for a transplant. And then that was in early June. And then in the middle of July last year, Rachel and I moved from Minneapolis to Cleveland. We'd gotten approved by the hospital and the organ board, and then got approval from the insurance company that next week. And July 20th of last year, I got listed on like the transplant wait list. And then in August, I started having a lot of trouble with my liver. I had a stent in my bile duct already, and that was getting plugged up again. I went to the hospital, we did an ERCP that cleaned it out. They told me it'd be the last time they'd be able to do that because they wouldn't be able to get the scope through again. Went home, and then about a week later, I got hospitalized again. I had a fever, I was very jaundiced and just wasn't feeling good at all. And then we were going to put a drain in my liver to try to relieve some of the bile. And the day that was scheduled, they told me that I had an offer for a transplant. So I think it was the next day, everything got sorted out and I went into surgery. So September 10th, it was like 17 or 18 hour surgery. And then I spent about 48 days in the hospital afterwards recovering. And then it was probably about 6 months or so, I would say, afterwards before I felt like good and was able to felt like I was doing stuff again. Now we're 10 months out last week. And yeah, so that's kind of my story. And from there, I'll pass it on to Dr. Grotz and Dr. Vaidya, and Dr. Lightner, who kind of made it all possible.
Yeah, no, thank you, Andy. And we'll be back at you with some more questions, but Dr. Grotz.
Yeah, I mean, thanks for sharing your story, Andy. And it's an awesome, awesome story. And just to kind of show how we connected the dots, and I've seen Dr. V, and can tell us too that, he did these transplants in the UK previously, and I'd seen their presentation at a conference, and kind of like Andy, I thought, wow, this is crazy and awesome. But it was in UK, and I knew the organ shortage was a big issue, and so I just didn't quite think it was going to be something that would be, for my something we could do for patients. And then Dr. Lightner and I trained together and then kept in touch. And then she let me know that Dr. V was now at Cleveland, and that this was something he was doing or wanted to start doing here in the States. And so about when we were talking about that, I thought immediately of Andy, just because I knew so frustrating not being able to do something for him. And so I immediately reached out to them, and Amy and Dr. Lightner and Dr. V, and told them about Andy, and that's kind of how we connected. And they've done all the hard work since then.
Amazing. Thank you. Dr. V, Dr. Lightner? Oh, you're on mute.
It's interesting to see how everything comes together in the end. I mean, I was in a different continent, different healthcare system and what have you. But there were repercussions of the work done in Oxford over here. I mean, Dr. Grotz had heard about it, Andy had heard about it somewhere. It seems that there's a ripple effect that sends these snippets all around the world. And we didn't do any big news story about it in the UK. It was taken on by, my first patient was a very famous rugby player in the UK, and he's got a foundation. He's got a Stephen Prescott Foundation for PMP in the UK, and there was a bit of news releases through the foundation and what have you. The UK, I must tell you, is a very conservative healthcare system, because they are very, very tightly budgeted for every process, every project, every new thing that comes along. It has to go through what's called as a national commissioning group. So if it is for something like transplants and intestinal transplants, they're limited to 2 adult centers and 2 pediatric centers for a population of about 80 million people. So not every center can take on intestinal transplants. So that's the healthcare system there. And then in that, when you come and propose that you're going to increase the indications for that procedure, it's actually, you need a lot of like-minded people around you for that. So when Stephen Prescott first approached me, he found me on the internet, intestinal transplant surgeon. He was ill with the disease from the mid-2000s, and ever since he had recurred and there was nothing he could, another treatment he could get done, he was looking at intestinal transplant. He was asking the question since 2006, and he got to me in 2012. So 6 years later, he found that actually someone in the intestinal transplant world may think of a transplant as an option. And for me, I've been thinking about this, for a decade before that, because I trained at the University of Miami with a very, very famous surgeon who actually changed the trajectory of my thinking. His name is Andy Voge. He was my mentor at the University of Miami. He's done a lot of work, with defining this whole transplant oncology interface. And he started with desmoid tumors. Desmoid tumors are, again, very, very slow growing intra-abdominal tumors. And, this was a natural extension to that. What we are looking for was something that, does not grow rapidly, does not metastasize rapidly, is contained within the abdominal cavity for a long period of time. And this is something that we could work with. So when Stephen Prescott contacted me, I'd not even thought about it. Pseudomyxoma, I knew what it was. It was one of the candidates for that would tick the right boxes for this transplant oncology definition. But the UK being the UK, healthcare being so tight in terms of budgeting, I was sure I would never get a patient referred to me. So in the UK, for example, PMP is looked after by 2 centers. Again, it's a high specialty, low volume center. So the government makes sure that all patients go to just 2 centers. One is in Basingstoke, which was close to Oxford, and the other one's in Manchester, Christie's in Manchester. So when Stephen came up and said, this is my problem, can a transplant help me? So I went around it in a different way. I said, technically, yes, it's possible, but I needed to have support. So I went back to his surgeon who operated on him in 2006. His name is Brendan Moran and Tom Cecil, the 2 surgeons at Basingstoke. So I picked up the phone and said, I'm coming down to see you guys. Can I, talk about a patient when I see you guys? So, and I had to see the cytoreductive thing. I knew from textbooks what it looked like, but I wanted to actually see what is entailed in it. So I drove down to Basingstoke, and they were very kind enough to let me into the operating room, and I saw them operate the whole day. And then at the end of the day, in one of the breaks, I said, I'd like to present this case to you. And they said, oh yeah, of course, we know Stephen Prescott. Well, what's happened to him? So I said, since you operated on him first, he did well for 2 years, and then recurred, then went to Christie's in Manchester, because that's what I said. He was St. Helens, a small town outside Manchester. And Christie said, we can't do much for you now. And so he was then sent, to almost like hospice therapy or hospice, a place to be comfortable rather than have any active treatment. So Tom then called his surgeon in Manchester and said, well, actually, this person's brought up another option, and I think we should look at that. So the important thing was it had to come from, the specialist in peritoneal malignancies, rather than me saying as a transplant surgeon that, yes, I can do it. And that was the key. And out here, again, the same pattern was, we had a conversation with Dr. Grotz after meeting Dr. Lightner here at the Cleveland Clinic. And I said, I've done these in England, and I'm sure there are patients here in the United States. But it was the way to get there was to actually, talk to, Travis and say, listen, do you have patients that do not fit the conventional ticket anymore? And that's where the conversation started. And it's almost identical to what happened in October, with the peritoneal malignancy team now supporting this as an option. And the algorithms have gone further in terms of identifying patients who may be advanced and having a cytoreductive or your HIPEC therapy may just prolong the time to a better outcome to transplant. So the Basingstoke people, and Adam Alderson was the first one who had that. He did not have cytoreductive therapy or HIPEC. He came straight to transplant. So that shows the evolution over the 6-7 years after I'd first done the procedure, that even the Center of Excellence for Peritoneal Malignancies, PMP, chose not to operate and send the patient directly to transplant. I'm not saying that's the way it should be done here. I think we should still follow conventional therapy first, and it's the prerogative of your physician who is looking after you as your primary physician to decide, who who goes forward for transplant, who shouldn't go. So I think that's where we would be looking at right now to provide this service. I keep on saying that it is quite new. Only 21 patients that have been transplanted over the last 10 years. And, we are learning, about the disease and the recurrence rates and whether it does recur or not, which one will recur, which will not. We are in that learning process also. But what we know is that the techniques to do that are well established. I don't have to reinvent the wheel, or the transplant community does not have to reinvent the wheel to see what kind of technique I'm going to use. Those techniques are absolutely robust techniques over the last 35, 40 years. We're just extending the indication. The question is where and how quickly should we extend that indication? And right now, our rhetoric is, if a person's failed all conventional therapy, then we may be able to help the right person. And that's where we are now. Now, the very important part of this whole story is Stephen Prescott, unfortunately, did not make it. He had what's called as graft versus host disease. It is something that can happen where the transplant organs attack the body. And at that time, 10 years ago, we did not have the treatment for it. I mean, the only treatment was steroid therapy. And he didn't respond to steroid therapy. And this time around, Andy also had graft versus host disease. It was quite acute. But this time around, Dr. Lightner and her team came to the rescue. And I'm going to switch to her. And she can describe the therapy that we got Andy involved in and how that dramatically changed the outcome.
Yeah, so there's some newer therapies out there that come from mesenchymal stem cells. And there's some evidence to suggest that mesenchymal stem cells can be effective in graft versus host disease, but there is a new product that has been developed in San Diego by Direct Biologics. And what the cells secrete as they're growing in these certain conditions is a very potent anti-inflammatory and immunomodulatory product that has really, really minimal to no side effects. And we have started using this in the transplant population in select cases. And you can go to the FDA and get an emergency use. So basically a patient presents, they've tried steroid or conventional therapy, it has not worked. And then we can apply the FDA to get permission to use this investigational product. And they usually will give us permission in 24 hours. So we went to the FDA and explained the situation, and they gave us permission to use this stem cell derived product. And it's very easy to use. It just gets sent in a little vial, and we put it into a little saline bag and it goes in the IV. And we're fortunate to be able to give this to Andy a few times. And he actually made pretty remarkable recovery within a few hours. I still remember going and he was itching uncontrollably from the skin manifestations, the graft versus host disease, and then recovered quite quickly after getting the product. So really exciting to see that.
So I think you look at not only was this first multivisible for PMP, but
Dr. V, I think we're having trouble hearing you again.
It's not only the first multivisual for PMP as such, but also it was the first time we used what's called as exosomes or extravesical therapy to treat graft versus host disease. And I wish I had that on hand 10 years ago, when I first treated Stephen Prescott.
Oh my God. That is just amazing. And listening to this story, I mean, this is not an easy road. The physical challenges for sure are difficult. The emotional challenges are also not to be underestimated. And so I want to turn next maybe to Rachel. And Rachel, could you talk about your perspective?
There we go. We're unmuted. Yeah, so I'm Rachel. I am the wife and caregiver So yeah, I've been kind of beside Andy. Obviously, I wouldn't not be. But specifically while he was in the hospital for the transplant, I went in every single day. I was more of a nervous wreck if I wasn't there. So I had to be there every single day. And it was not an easy walk in the park at all. Just to be there witnessing him and his physical kind of struggle and the mental struggle. And then also to be the person that has to be the uplifting, supporting one. As many caregivers know, that can get very exhausting really quickly. So it was a struggle, but there was a lot of really good, joyous moments throughout that whole process that kind of helped us get through all of it. But luckily I had my mom here. She flew in the day before we actually got an organ offer. She decided to come in and just visit. So she was here every single day too to help support me and pick me up and drop me off and make me dinner. And she was behind the scenes helping me.
I think it's crazy like how much Rachel grew during the process. Like the first surgery with Dr. Grotz at Mayo, and like after I came out of surgery with, you know, like an NG tube.
I almost threw up looking at him.
Yeah, all the lines and everything. But then to like after transplant, I had an NG tube for like almost a month, multiple, because I kept pulling them out. And so like just for her to like how much she had to get comfortable with in that process.
Yeah, really quickly. And to like, there was a point where he was getting sutured up in his room and I just watched it, and I wouldn't have been able to do that 2 years ago. So there's a lot that you kind of learn and get used to along the road. Journey. Yeah.
Yeah, I mean, the emotional resilience for both patient and caregiver, and I think also the medical team. I mean, you know, so important. So many ups and downs, and you know, again, not to be underestimated. So I think with that, I mean, I mean, we look at Andy, you know, every week on our calls with your baseball hat, you know, just a regular guy. And we would never imagine you've been through everything you've been through. And so to hear this story of hope is just amazing. Now we did feel free to continue to and Tara makes a good point, and you did this through COVID. Yeah, that added one other complication to everything. So we had a number of advanced questions, but also feel free to list some questions in the chat. I'm going to move our most popular question up to the top, and that is, we have a number of patients that have small bowel involvement. And as Dr. Grotz had mentioned, you know, quality of life is for the patient is always a consideration when CRS and HIPEC is done. And so you know, many of our patients that have small bowel involvement, you know, aren't as eligible for these conventional treatments. You know, Dr. Lightner, could you talk about a patient that just has small bowel involvement? Is it possible to just transplant the small bowel, or would this involve a multivisceral transplant, and what organs would need to be transplanted?
It's set up so that you can't unmute yourself. You have to unmute Amanda.
Oh, okay. Let's see. Sorry.
Thank you, Andy.
There you go. Sorry.
So yeah,
Oh, for whatever reason, yeah, we still can't quite hear you.
so I'm not sure I know the answer to that question, whether you're going to have only small bowel disease. It is possible. It is possible, but given the nature of this, this process with the jelly-like substance, it's got, it's got the ability to go to the whole abdomen and stick onto the different surfaces. So the chances of having only small bowel involvement, I haven't yet seen it. I've not seen many patients, but it is, I'll know when I see one. I think of the last few that I've seen after the old news broke. Of them, one may be just the encasing the intestine, and but usually, the disease process is in three compartments. Is that between the liver and the stomach, then the pancreatic complex, and the root and mesentery, and the small bowel and the pelvis. So these three compartments is what we look at, and it might turn out that there is a patient out there with only small bowel involvement. But that could be because the primary operation of debulking or CRS, cytoreductive therapy, has really done a fantastic job, in the parietal region, so around the stomach and what have you. And unfortunately, you just can't touch the visceral peritoneum, the peritoneum that covers the intestines, and that might lead to an incomplete resection at that point, and we bank on the HIPAC to take care of that. But Dr. Grotz might be able to expand on that.
Yeah, I mean, as you mentioned, it's often the kind of, I call it the rate limiting step. I mean, we usually can clear the stuff on the abdominal wall and the diaphragms on the surface of the liver. That's usually pretty easy, but it's usually the small intestine or colon. And there's a certain amount of it that we can remove and still have reasonable outcomes. And there are some people who have stomas or other things that that allow us to remove all the tumor. And so, but if we get under such a amount of bowel, people may be either dependent on nutrition through an IV or need IV infusions periodically, or have diarrhea or high ostomy outputs where they have to manage that. So it's a balance, as a cytoreductive surgeon, trying to achieve complete tumor removal, but also give patients reasonable quality of life. So it's different for every patient and where the tumor is, and every situation I've had has been different. I don't think any two patients have the same distribution of disease actually. But yeah, it's usually the bowel. That's usually what limits us. And that's in Andy's case, it was the stomach and bowel as well that prevented us from being able to remove it all.
So from both the cytoreductive perspective and the transplant perspective, what is it about the small bowel that makes it so much harder to deal with?
From a cytoreductive standpoint, I guess, like I said, you have to have so much remaining small bowel, and if you peel the tumor off the bowel, every time you do that, usually you make a little like a little shaving defect or like a little nick, and you got to repair those. And or if it's in a certain segment of bowel, we can remove that section of bowel and hook it back together again. But every time you make a connection, there's always a small chance that may not heal and it could leak. And so it's additive. So if you do one connection, no big deal. Mostly patients are going to do well. But if you can imagine in a situation where the entire bowel is covered, and you're doing hundreds of these little nicks, or you're doing 4, 5, 6 connections, now the risk gets really high. And so I'm sure many people on this webinar thing, fistulas and bowel leakage is a problem with pseudomyxoma because of the extensive bowel involvement and trying to be aggressive surgically. And so that's where we can lead to if we're too aggressive or too or not, with that.
Thank you. With the multivisceral transplant, which organs were transplanted and do they all come from the same donor?
So yes, they all come from the same donor. And the organs that we transplanted were the liver, the stomach, the pancreatidymal complex. We had a spleen at the end of that pancreatidymal complex. We got the small bowel and the large bowel. There's the right colon. But after the transplant, we choose to take the spleen out after it's done its job in the first few hours after reperfusion. And I'll expand on that. And the right colon, I'm happy to keep it if there's enough space. But if there's no space and it's going to be a very tight closure, I'd rather take that because that takes out the space. It gives you more space to close the abdomen. But it serves its purpose in the first few hours after reperfusion. The spleen serves its purpose because it is the spleen is drained by what's called as a splenic vein, and the splenic vein leads up to what's called a superior mesenteric vein that becomes a portal vein and flow into the liver. If you take the spleen out before putting the organs in, the splenic vein is a high capacitance but very low flow system, and it's prone to clotting. And therefore that means some of the blood supply going to the liver has clotted. We don't want that. So what I do when I do a multivisceral transplant is I keep the spleen attached and let that circulation get matured, and the whole reperfusion injury to the endothelium or the inner lining of the splenic vein is overcome after a few hours after the transplant. That's one reason. That's an anatomical reason. The other reason is there is an immune advantage to have the spleen mix with the recipient blood, because the spleen, what does the spleen do? Is the spleen in our body is normally the spleen helps to cull or kill, cells, immune cells that are senescent. So, those that have done their jobs will go to the spleen. That's the culling factory, and the DNA is sent out into the blood. That's what the spleen does, in short. So in the transplant setting, you can imagine now this is a spleen that's not the recipient spleen, it's a donor spleen, but the recipient blood is going through it, and it should do its duty and start culling, but it doesn't. For some reason, there is a switch off mechanism which gets ingrained into the memory of these immune cells. And the same thing happens in the lymph nodes in the intestine that we transplant. So that same information from the spleen is sent to the lymph nodes, and they all both have the same information that actually these new cells coming through are friends, and there's a protective effect. And that usually happens within the 2 or 3 hours after the transplant has, the organs are reperfused. After that, no one really knows what is the advantage of leaving the spleen in there. No one really knows. Some reports from Miami, from my mentor, was a keen proponent of leaving the spleen there. And some of the people out there who do intestinal transplants say no. So it's a divided vote. This being the first one for this indication, I didn't want to take any chances, so we took the spleen out when it had done its job of immune recognition, and that's where the spleen came out. As for the colon, I think it's also this is work in progress, because we think that the colon's got a signature, a molecular signature of the bacteria inside the colon, and that has to come in and get recognized by the recipient's blood. So this is the thought process behind it. If there was space with Andy, I would have left that colon, Andy, and I would have brought up a colostomy rather than ileostomy. But since there wasn't any space, it did its job. The immune recognition for the microbiota was done, and I was able to take it out. So altogether, liver, stomach, pancreatidymal complex, small bowel, large bowel, spleen. So 6 organs.
Oh, that's incredible.
And it's all done once. I mean, the beauty is when you do a multivisceral transplant, it is the easiest operation to do because there's only two connections. One is a connection going in, one's a connection coming out. So it is truly an easier operation to do.
Wow. Oh, we just had a good question in the chat. Do you get a donor appendix too? So do our patients get their appendix back?
So you do get a donor appendix, and I usually take it out.
Oh, thank you. Oh gosh. What would qualify a patient to get on the transplant list to be eligible? What kind of testing is done? How do they qualify?
Okay, I'm gonna let Anita answer that.
Okay, Anita.
So it's fairly intensive. We do, to qualify for transplant, we need to make sure that we can do it safely, that we can technically do the transplant, and that it's going to be beneficial for the patient. So in doing so, we want to make sure we leave no stone unturned in evaluating every patient. We're looking for things they may not even know that aren't quite right in their bodies. It might be clotting disturbance or a tendency to bleeding. It may be infections they need to be protected from. It can be hidden cancers or infections they're not aware of, as well as clot or other strictures of blood vessels. So we're looking at the heart, the lungs, we're scanning the whole body to make sure there's not hidden cancers. We're doing intensive blood work to make sure we're finding no anomalies, because we don't want any surprises post-transplant. There's a lot of things that we can address and make it safer for the patient to be transplanted than if we've never looked and then are faced with a catastrophic issue post-transplant. So there's a number of tests that we'll do. I look into the history of every patient to see what's already been done, so we aren't repeating testing if we don't need to. We're mapping blood vessels to make sure our anesthesiologists can get good access. We're mapping the blood vessels of the abdomen, so Dr. Vaidya knows exactly where to make all the anastomosis or connections, so those organs get good blood supply as well as good venous return from those organs. And we're also pulling in a lot of consultants. So our anesthesia team evaluates the patient, infectious disease, our social worker. We also have other specialists that come in when indicated. We may need cardiology clearance or pulmonary clearance if somebody's been a smoker. So, but it's all tailored to what that patient's history is and what their symptoms are, what we have to mobilize and test for each patient. The evaluation takes about a week. We can do it outpatient, but there are circumstances where it makes more sense, depending on the condition of the patient, to do it inpatient. But it usually takes about a week for us to gather all the information we need to be able to make the right decisions and what we do for that person.
Thank you. Is age a consideration?
It's not so much a numeric age, it's what's their functional status. So there can be 60-year-olds, 70-year-olds who are very active and or have been active and aren't extremely debilitated. There can be ones who are younger in their 20s and 30s, and it may be because of other illnesses they have on top of their PMP that has made them more debilitated, but we take all that in consideration. It's not so much the number, it's really how they're functioning.
Thank you. You might have seen the other question in the chat. So patients that have gone through CRS and HIPEC, could those patients be donors? or because of the treatment, does that make those organs not eligible for being donors?
So I'll answer that. I think in terms of abdominal organs, I would say they would still be kidney donors. But I don't think we would, or rather the transplant community would consider a a liver, for example, that's got all PMP encased in the blood supply as a potential donor. You would take lungs if the lungs were or the heart if the heart is strong, and there's no other issue with the heart.
Okay, thank you. Let's see. Could you, you talked a little bit about the history. So could you expand on that, the worldwide, the history of transplants? Is it just in the UK and then here? Are there other areas of the countries? And, do we, have we had enough cases to follow these patients?
So it all started 10 years ago. The first one that I did. After that has been, Andy was number 21. So, and it's only in 2 centers. One is in Oxford and one's here now. But I'm sure, other centers will pick it up. In England, they didn't pick it up because the other center was Cambridge, and Cambridge cannot be number 2, you see. Cambridge has to be number 1. Unfortunately, this time Oxford was number 1. I'm kidding. But being two adult centers, I think they are they're welcome to do them, and it is something that's now registered as a definite option in pseudomyxoma. So in the UK, Cambridge may start doing it, but right now it's only Oxford.
Just to add, I know Dr. Vaidya could expand on this, but that's just transplants for PMP. Like, they do a lot of multivisceral transplants. Like, the transplant procedure isn't anything.
No, you're absolutely right. That's what I said earlier, is that transplant procedure as such is a well-known procedure. We've been doing it for the last 35, 40 years. And that's not the issue. We've actually refined our techniques and what have you, multiple times over. I think we're at the peak of our understanding of multivisceral transplants. The technical, not there's a lot of evolution still in the immunology and acceptance and tolerance and what have you. But in terms of the actual procedure, you can teach anyone to do that.
Yeah, thank you for the clarification. What are some of the potential side effects? I mean, as Rachel has pointed out, it's not been easy, and practically a year later, Andy's finally moving back home. What were some of the rough points, or what are the things you look for after the transplant is done to make sure the patient is on the right road?
So essentially, it's immediate things you look for in the first 2 weeks, 3 weeks during the hospital admission. Then there's intermediate things you look for, in the intermediate term is between 3 to 6 months. And then the first year and then onwards. The first year is most intensive. And all these things are bunched up right in the first 3 months. So right from the operation, any operation you do could have a complications. Most, we're joining blood vessels together, you can have bleeding. We're joining, intestines together, you can have a leak from the intestines. We are using lines, you could have line infection. We overload a lot of fluid. You could have a lung collapse or fluid buildup in the lungs. You could have blood vessels that clot because it's in hypercoagulable state. So you could get DVTs in the initial period of time. That's the constant of the first 2 or 3 weeks. Once you step out of that, immediate complications, infections inside, collections, needing another operation. Once you step outside that realm, then we're looking at immunological complications, either body attacking the graft or graft attacking the body. And this is what we keep in a very good lookout for. For that, we have biochemical markers, your liver enzymes and what have you. And we do what's called as endoscopy. We do an endoscopy through a little chimney that's brought out to the skin. And we take minute biopsies and analyze those biopsies on the same day read. And if there is any suspicion of what we call as rejection, that means body attacking the graft, we will treat it. And rejection in today's day and age with the sophisticated drugs that are available is actually more of a nuisance value for the patient. Because if you have rejection, you need to stay in the hospital a bit longer, getting that treatment and what have you. Rejection in the early days, when the drugs weren't that sophisticated, was quite dangerous, because if you couldn't rein in that immunological reaction against the graft, the intestine is a very sensitive organ in that it's got a barrier. You see, there's bugs in the center, and there's a blood vessel on the outside. So you're eating food, it goes into your intestine, and those nutrients are absorbed. But there's a barrier there that doesn't allow the bugs that are inside to go into the blood vessel. When you have rejection, in the old days, the rejection would come up and it was quite, you couldn't control this rejection. You would have breakdown of that barrier, and now bugs are going into the bloodstream directly from the intestine, and that's causing sepsis. In the face of sepsis, this rejection and sepsis because of rejection, I would have to increase the immunosuppression to depress the whole immune reaction in the face of sepsis, and that was the problem. Things have changed dramatically. Our drugs are so sophisticated now. Our induction therapy is so sophisticated. Where now actually most of the patients would be on a single drug regimen called Prograf or tacrolimus in the post-op period. Because what we've understood in the last 20 years is that less is more. The less immunosuppression we give is better for the patient, as long as you've loaded the patient, to begin with what's called as induction medication. And what we use is a very unique drug called Campath. And this is perhaps one of the only centers that are using Campath, but keeps the patient safe from rejection. So that's the immunological barrier that starts playing up, after the first month, 2 months, and that threat of rejection is still there for the whole year. And it's anything between 6 to 13% chance of having your first episode rejection the first year. After the first year, something dramatically changes. And it's almost like, okay, I can't fight you, let me be your friend. And there's a sense of acceptance of the organs. It is like a light switch on and off. And therefore, after the first year, we start decreasing the cumulative immunosuppression that we're throwing at patients. Because, you're decreasing immunity in the long run has its own problems. So we try to curtail those problems by decreasing the amount of total immunosuppression that we give. So immediate complications, and we've got to look after that, intermediate, and the long term. The real long-term ones are, especially in PMP, is to look at tumor recurrence of the tumor. How much has it recurred? Is it life-threatening recurrence? We have to really chase it. Is it going to grow very slowly but remain indolent there? So these are things that are now things that we're learning, in the last 10 years.
That's amazing. So once Andy hits the 1 year mark, so what kind of monitoring is there? I mean, I assume there's continued follow-up, but spaced out, or how?
We don't want to see him again, do we? No, we'll entertain him once in like 3 months.
I suppose, Andy, from your perspective, you just know. I mean, you would probably be so intuitive about what might feel off versus what feels normal. But
yeah, I mean, it's pretty obvious, I guess, now by this point, for probably all of you, like when something's off, like, you know, pretty quickly. And Dr. Vaidya and Dr. Lightner have been terrific. Like if anything happens, just call them and we get it taken care of right away. But yeah, so I think that was the biggest fear getting into it, was like I didn't know anything about transplant. And so like you hear people talk about rejection, and like I just assumed like if you get rejection, like the organs just stop working and you die right away. And so it was very reassuring to know that that wasn't necessarily the case. And then with the use of ExaFlow with Dr. Lightner, it was amazing how quickly mine turned around. And so that's been very reassuring as well.
well, and I'm sure you know, Andy does tell us about the long cycling rides, hiking rides, all these outdoor activities that he's able to do at this point, which is just amazing.
Yeah, that's been great. There was a question, I guess, about like quality of life afterwards. I guess I'll touch on that quick. Like I didn't eat going into the transplant. I hadn't eaten for about 14 months. Like for substance, I would like chew on food for flavor, but I didn't gain anything from it. So after the transplant, I was able to start eating again. I eat a pretty much regular diet now. And I put on like 35 pounds since I left the hospital after the transplant. And yeah, like Adele said, I started biking again probably about 4 months ago. I'm doing a 100-mile ride in August, so I'm training for that right now. So I got a 50-mile ride tomorrow. But yeah, I mean, I'm as good as I could have expected going into it. Like going into the transplant, my goal was to be able to eat again. And I think like the results have far exceeded what I expected to be able to do afterwards.
Yeah, it's quite amazing. Vaidya at one point said at like the 5-6 month mark, you start to notice a difference. And at 5 months, I did notice a difference of Andy getting back to his regular things. He's now the Andy that I married a long time ago. So it's just fun to see him now back to, I don't know, his normal self pre-cancer. So it's been, definitely do not regret the decision we've made, even though along the road there have been points that were like, what on earth did we decide? Why are we doing this? But yeah, don't regret it.
That's awesome. Now, technically, Andy is cancer-free. So a couple of the questions with any of these transplants, is there a chance of recurrence with regard to the cancer?
So there was, technically there is. We take out, I would say, in the late 90% of the tumor that we can see. That's not been our experience though. In the last 20 cases, there was one that did recur, but that was with pseudomyxoma that we knew was already on the peritoneal, on the pleural lining on the left lung. But she was completely obstructed. She elected to have the transplant. She went on 5 years with that transplant, and it was the lung part that came and that was the end. But at that point also she refused to do anything about the lung part. She said, I've enjoyed the last 5 years I've had. I don't want to be subjected to any further operation. So that's the only recurrence I know. It's not a recurrence, it is an old occurrence that grew. Nothing in the abdomen. But it's possible.
You know, for a potential, I don't want to say maybe a potential transplant patient, but for somebody that, you know, maybe our conventional treatments, you know, might not be 100% effective. What is your view on, you know, the high doses of chemo with the conventional treatment versus maybe being tested for a transplant? I mean, is there a point where, and maybe Dr. Grotz, you could weigh in on this too. What is that judgment between continuing with a conventional treatment versus suggesting exploring a transplant?
Sure. So it's different. So there's different types of appendix tumors. And so, you know, Andy had the low grade Lamin version, which we know does not respond to chemotherapy. And so I never recommended chemotherapy to Andy, and he mentioned the only reason why he ever took it was to be eligible for a trial. But so if we know that it's a low grade tumor, we typically don't. I mean, sometimes people will try it because, you know, we didn't have much other options once surgery wasn't an option. But you know, we typically don't recommend chemo for low grade tumors. Now, high grade tumors are very different, and so that's where it can get kind of confusing. Because they do have the risk of spreading outside the abdomen. So they can go to the liver or to the lung and be inside the organ. So what we're talking about with PMP is on the outside surface of organs. But how it gets inside the organ is through the bloodstream. And if cancer can get into the bloodstream, then even a transplant can't get rid of all the cancer because there's cancer in your blood everywhere in your body. So so for high grade tumors, you know, then we do often sometimes give chemotherapy because again, chemo in the blood can kill those cancer cells. So the treatment, I guess, varies by the type of tumor of appendix cancer, and that's why it's very individualized, and why people really know you need to go to, you know, high volume centers that deal with this a lot, so that people can navigate all the different types of appendix cancer.
Thank you. And we had a question there. If you had high PEC, can you be eligible for the transplant?
Oh, yes, of course.
There was a question in the chat for Rachel. Rachel, what are you doing for self-care right now?
I was just going to respond to her. Right now, I am doing a lot of running. I ran some marathons a couple years ago and kind of stopped doing that due to circumstances. But yeah, I got back into that, and that's been my biggest motivator to get outside and do something and push myself. Yeah.
Well, we certainly see the relief on your face.
I think the biggest thing is like her being able to feel comfortable like leaving me for any length of time. That's been a big step, and I think an important one for me.
Yeah, I don't have to babysit him all the time now.
Oh, goodness. And let's see, we had another question in the chat here. I'm trying to get to it. Is transplant an option when there's growth on the hepatic artery?
Sorry, say again.
Let's see. Is transplant an option when there's growth on the hepatic artery? Maybe I'm
So it all
saying
depends,
that-
you know, what does that mean? Is that because it's encasing the hepatic artery, or is it inside the hepatic? What is the question?
I don't know if the person wants to expand, but the question was phrased that there was a growth on the artery.
So it really doesn't matter. Even if it's encasing the hilum, we can strip all that out and manage to keep the blood supply going. Obviously, we may not get, you know, all the clearance out at that point, because, you know, you can't just, unless you're going to replace the liver, but that will not qualify to replacing the liver, because you know, in Andy's case, he had venous thrombosis because of pressure in the liver, and that was one of the things that helped him get the points. And of course, he was obstructed, his bile duct was obstructed, his bilirubin was high, and he got the points that allowed him to get a liver. But only having disease process around the hepatic artery, it doesn't warranty a liver having, as being part of the graft. So we can take it off.
Thank you. If someone had 2 previous HIPAC debulking surgeries with a large amount of small bowel resection, would a transplant be possible?
Yes.
Okay. As we talk about all of this, it sounds very expensive. And so have there been challenges in terms of getting insurance to cover, or do you find patients need to use their own resources to supplement what insurance covers, start GoFundMe accounts, things like that? But has that been a challenge for getting patients in to get it paid for?
So, this forum, I'd like to just contribute to the science bit of it. And, these other issues I don't think I'm qualified to even, touch those issues. So I'll refrain from answering that.
No, that's understandable. And each insurance company is different, but hopefully the education continues and we keep making progress. Let's see. Trying to get to a couple of these other questions while I find them. I know I saw one in there that for as challenging of a journey this was for Rachel and Andy, could you share a moment of joy?
Let's see, moment of joy. That he's here. That's a good joy. Honestly, it's been my biggest joy is just seeing him back to himself. Andy's very much our friends call him Handy Andy, and he's always tinkering around, working on building something. And so just to see him back doing that has been a big joy, just him enjoying what he loves to do. Anything?
I mean, there's been a lot of little moments of joy. Obviously, the first time we got to go out and go for a hike was great. It's just to be outside again. And I mean, even prior to the transplant, after we got diagnosed, we sold our house and bought a fifth wheel to travel. We did a little bit, and then COVID happened, and that kind of stopped for a while. But and those are things that we never would have done, I guess, without the cancer diagnosis. And so yeah, there's been a lot of sources of joy throughout it, and it's really just taught us to just focus on what we can do right now and do what we can today, and tomorrow's going to happen how it happens, and we'll just deal with that then.
Well said. Yes, your perspective of time certainly changes. Question: is it possible to transplant only the sigmoid colon down to the rectum?
It's not yet been done, but we're working on it.
Okay. And then I think just another question on Andy's case. So even though you had low grade, it was your tumors were hardened, and that was the main reason the conventional treatment wasn't working.
I'm sure Dr. Grotz could speak to this. I could, because he saw it. But yeah, it was just there was too much tumor involvement around my liver and stomach that it just couldn't be removed.
Yeah, I mean, I had limitations with my ability to reconstruct because I didn't have organs. So, if we took out his whole stomach, we'd have to figure out a way to attach his intestines to his to his esophagus and reconnect them. And so, but his intestines also had tumors. So there wasn't a way for me to remove all of it and put him back together again in a meaningful way where he could eat again and do as well as he's doing now. So, so that's kind of why we couldn't do more surgery.
Interesting question. If there is recurrence after the transplant, then could that patient get CRS HIPEC if needed?
You know, that is really, really interesting. I've toyed with that idea in my mind, and I'm sure, you know, we'll come to some kind of conclusion along with, you know, Dr. Grotz, and, you know, gets all these opinions together. And you know, that might be the first one out there.
Yeah, very, very interesting. Is there a point where the tumor burden is too much for a patient to qualify for a transplant?
So we haven't got that criteria as yet. Our criteria is that it should not be outside the abdominal cavity.
Okay. Working my way through the questions. Could you repeat again all of the organs that were transplanted for those that might have joined us late?
Andy, do you recollect?
He is in.
Okay, so we did a liver, we did a stomach, we did a duodenum, we did a pancreas, we did a spleen, we did a small bowel, small intestine. Small intestine got the jejunum and the ileum, and we did a right colon. So I don't know how many were there, 6 or 7.
At least. Thank you.
But all of them were, it was a singular blood flow in and a singular blood flow out. That's the advantage of doing a multivisceral. You're not spending hours putting each organ in differently.
Mm-hmm.
It's like a cluster of grapes. I've given you that example before.
Mm-hmm.
There's a cluster of grapes. You buy a cluster of grapes in the supermarket. You keep that, and you buy another cluster, and you take all the grapes out and keep them separate and see which one dries up first. Is the one that you separate out will dry out first. So there's something about a common blood flow, common channel of existence that helps in the organs doing better. It's called the cluster theory of multivisceral transplants.
That's a good analogy. That is. There is a question in here about the outcomes of the other 21 patients.
So those outcomes, 20 patients before Andy, of which the first one, as we already described, Stephen Prescott, he didn't make it because of graft versus host disease. The second one was the one that had the lung disease before we transplanted her. And the third was an unfortunate lady who had a fungal infection of the blood vessel that connects all the blood into the intestine, and that gave way, that burst. So there are 3 people who didn't make it through the transplant process out of 20. Now 21, so 3 out of 21.
Thank you. Is it possible to just have a bladder transplant or a rectum transplant?
So the rectum transplant not yet been done. A lot of work's being done on it. Bladder transplant, there is a group up in I think it's Chapel Hill in North Carolina. They're using regenerative medicine to regenerate the bladder and then implant it, not transplant it.
Is there an ideal candidate for the transplant?
An ideal candidate is one that doesn't have disease outside the abdominal cavity.
Okay, thank you.
And of course, has got good heart, good lungs, anesthesia's happy, enough lines to put lines in, and has had no other comorbid issues that will create a problem during the transplant process.
Thank you. So what should we as patients do when, to consider this? Would you rather test a patient earlier just in case they might need a transplant, or should patients wait until they have no other options?
It's a very good question. And right now, I think we're in this situation where we would wait till the primary physician thinks that there is no other option, because we want to have all conventional options taken first before patients are sent over for transplant. Dr. Grotz, I mean, you could weigh in on that one.
Yeah, I mean, I think if patients are candidates for complete cytoreduction, I think then that's should, or at least as of now, should be the primary goal and treatment. But I think if that either results in unsatisfactory, a short gut or other reasons, or if they no longer are candidates for complete cytoreduction, and they otherwise meet criteria, then I think transplant's now a viable option for that.
And we know Andy's case was low grade, but if a patient has, signet, goblet, high grade, would they also be eligible for a transplant?
So, that's an interesting question. Again, the jury's out there. We've done only 21 patients, so I don't think we're in a position of, being able to judge on that. Only time will tell. We will learn from our own, thought processes and our own outcomes. And what we promise to do is keep a very stringent, almost like a policeman on our results, and make sure that we evolve as this whole process evolves.
Thank you. Is there a long wait list? Because we know it's timing. You're waiting for a donor, but are there many patients waiting?
So that can happen. Usually with multivisceral transplants, we are very stringent in the criteria for organ acceptance. But there is, and that's for multiviscerals or modified multiviscerals for disease processes that are not cancer. Now, when you're dealing with a tumor, you are on a tumor timeline too. So we as transplant surgeons have to start looking at options that you would turn down ordinarily because of A, B, Z, whatever metric. But I think the time has come to actually look at those metrics with scrutiny and see whether they are objective metrics or were they subjective metrics from your mentors or where you trained and where you got that transplant training from, and explore those many donors that are out there that might benefit your patient.
Thank you. And then I think the question also in the chat, is there a surgical oncologist that's present during the transplant, to clear away any disease from organs that might not be removed?
Oh, we would love that. We're trying to get Dr. Grotz to be involved.
And would HIPEC be something that would be done, or is that not something that would be needed?
So, with the first one I did, I thought about HIPEC because that was a modified multivisceral, and I'd gotten very good clearance of the disease process. And I thought, logistics was so that I was still waiting for the organs to arrive. And that thought crossed my mind, but we didn't go ahead with that. And subsequent cases after that we've done, We didn't do HIPAC, and we haven't seen the benefits of HIPAC in this situation. So we haven't yet done it. We may, I don't know.
Okay. We are actually nearing the end of our scheduled time. And so two things. I was hoping maybe each of our guests could just give some parting comments. And if there are any questions on topics we didn't cover, I think we have probably just a few minutes. So I will start with Dr. Grotz.
Just thank you for having me, and it's just been a real privilege and honor knowing Andy and Rachel and just being part of this. So thank you very much.
Thank you for being here. Dr. V.
Oh, again, thank you for having us on this panel and being able to answer most of the questions, not all of the questions. And what we're trying to do is spread the concept of hope. I mean, there is hope around every corner. You just can't give up when things are, your back's against the wall. Stephen Prescott didn't give up. He started this. His back was against the wall. He fought against so many odds and made himself available for that. I mean, he's the one who opened the doors here. So, he didn't give up. He said, no, he looked for that option and he got it. So in my books, the thing, never say no and never say it's not possible.
Yeah, well said. Well said. Our line at PMP Pals is we have hope for you, and so important. Dr. Lightner.
I just want to thank Andy and Rachel for really giving back to the community. I think what they're doing is fantastic. We're all very happy, obviously, that Andy is with us to be doing this, and just really proud of the two of them for giving back to the community and educating the community and showing that there's something else out there. So a huge thanks to what they're doing.
Thank you. Anita.
I would echo the same thing. I think it's so powerful with them sharing their story, and they're so generous with their time. I mean, we've had other patients, Andy's like, no problem, give them my information, and they share. Not only do they share, they really try to help anybody else pursuing the options and make themselves available. So they're very generous and wonderful people. And it's giving us an opportunity to help others. So we're excited about helping others and having more success stories. It's been a blessing and a privilege to take care of them. But it takes a huge village. It's not just us on this screen. It's all of our inpatient team, op team, lab folks. There are so many professionals here and at the Mayo Clinic who have touched their lives and helped lead to such a wonderful outcome. And I want to recognize them as well.
Rachel.
Yeah, I mean, the reason why we chose to share our stories because there's people out there that this is going to be an option for treatment. And so just in a couple of weeks to be able to see that has been amazing. And yeah, just very grateful for the Cleveland Clinic and Mayo and just the opportunities that were opened up to us. And yeah, you guys are awesome.
Oh, thank you. Andy.
I guess I'd just echo what Dr. Vaidya said, and it's about realizing that there's always some hope. And I mean, Dr. Grotz was amazing. Even after there was nothing else he could do, he didn't give up, and he referred me to Dr. Vaidya, and that never would have happened without him being diligent on a case that he couldn't actually help with. And then yeah, just them, Dr. Vaidya, Dr. Lightner, Anita, everybody at Cleveland Clinic for facilitating all of that. And I remember what it was like leaving the hospital in February and of 2021 and looking at, probably having to go into hospice and like getting stuff ready to die. And that's a terrible experience, and I wouldn't wish that on anybody. And so to then a couple months later have like this complete reversal and have like a glimmer of hope, and then to go through it and now, you know, still be here is amazing. And I feel like the least I can do is share my story with other people. So yeah, thank you guys for listening and for letting us talk. And yeah.
Thank you. I mean, this is just incredible, and it's, you and Rachel are such an inspiration, and the promise of hope with the medical specialist. You know, so we hope for everyone joining today that this gave you hope, and this gave you education. And we will record this, you know, on our site. So please feel free to go back and view it. But our heartfelt thanks to all of our guests. We can't thank you enough for spending your time with us this evening. We appreciate it.
Thank you.
And you say everybody's
Thanks.
Thank you.
on mute. Oh. Well, thanks again, everyone, and have a great rest of the evening.
Thanks, good night.
Bye.
Good evening.
Thank you. Good night.